Hi, I'm Dr. Domingo Molina, and I'm an orthopedic spine surgeon. Hey everyone, Dr. Molina here again. Today we have a pretty interesting case. It's a 52-year-old male with right hip pain. Patient does not endorse any left leg pain, uh, and he also endorses pain only in the right hip area. It doesn't radiate down the leg or to the foot. He uses a cane for balance at times, failed conservative measures, no other neuro exam findings, no motor neuron signs. Strength is good. He's a veteran. I comment on the fact that he's a veteran because I like to kind of evaluate the patient that I'm dealing with, whether they're employed, what their hobbies are, what kind of goals they're trying to get back to, and this helps me diagnose, what the problem is in most cases. So we'll move forward through the MRI here. Look at this area of kind of bony protrusion here at the facet joint. And so I'll scroll through the sagittal. You'll see that he does have stenotic foramen at the L5S1 level. And so you kind of wonder, is this going to be the issue? But patient doesn't have any pain on the left side. And so as you scroll through the axial, you'll see here the increased hypertrophic facet on the right side, causing lateral recess stenosis of the L5 nerve. And so I really thought that this was the patient's pain generator. Some of this is nerve stress due to the spondylolisthesis, but I think a lot of it, especially on the sagittal view, is bony stenosis of the traversing L5 nerve root. And so I kind of came to this conclusion when the patient was only complaining of right hip pain and also didn't fully travel down the leg, and he had no pain on the left side. So we indicated a hemilaminotomy and decompression of that lateral recess. So this is the initial start of our decompression. I'd like to use the pituitary here to, one, obviously remove the superficial layer of the ligamentum flavum. I also like to try to feel around for the bony anatomy, so I'll look for the inferolateral edge of the L4 lamina as well as the superior lateral aspect of the L5 lamina. And so this kind of gives me a direction of where I'm going, where I'm at, and how far to straight out laterally to start my hemilaminotomy. So of course I'll make sure I control all the bleeding here. Again, I've started as of over the last few months to put epi into my saline bags. Again, this really does help with bleeding control. And again, I use the RF probe to not only control bleeding, but also to use it as a probe to check my bony anatomy as well. And so I know here that I'm already kind of at the joint here, and I went into this area because I know that I have to decompress the lateral recess and and take part of the facet joint laterally. So I'm clearing this out, trying to get a feel for how far I want to extend my decompression laterally. Of course, you don't want to destabilize that segment, and so I always make sure that I use the diamond burr to kind of measure how far I'm decompressing laterally. So I use the punch here also to remove some of this ligamentum flavum. It's a little bit quicker because I can just kind of chomp at it. I also like to continue to use the punch to essentially go through the ligamentum flavum to get an idea of where I'm at within the spinal canal. And so you'll see that I'll do that here in a second. And so now that we've got our entrance to the spinal canal, you can see the dura there. I'll leave that there, and I won't continue to enlarge it because I want to protect the dura from the diamond burr when I perform my hemilaminotomy. And so, but at least I can assess that my location of the traversing nerve root, and this will give me an idea of how far I need to decompress laterally. I think it's important to not extend the cranial aspect or the cortical decompression too far laterally. So you'll see that I stopped here. It's approximately, I'd say probably about 5 or 6 millimeters. It's a 4.5 millimeter diamond burr, and so you don't want to extend it obviously past 8 millimeters in order to prevent destabilization of that particular level. So what I'll do here is I'll kind of extend the cortical decompression, and then I'll start to do the cancellous portion and the deeper portion of the lateral recess. And so you saw that I kind of pushed my camera down there. I was wiping the camera on some of the soft tissue to kind of clean it. Here I'm removing the tissue around the bone, and this is important because you want to make sure that you get a good visualization of the bone when you're using a burr, because if not, then you can stray into the canal, or potentially you get the tissue wrapped up and it just takes a little bit more time to see what you're doing. So here I've extended the decompression to the superior lateral aspect of the L5 lamina. You can see some of the joint there, and it's a little bit interesting right here, I'm using pituitary. You can see a little piece of an osteophyte, and that is essentially what we saw in MRI on the sagittal and axial view of that particular bony hypertrophic facet. And so you can see that I didn't separate it from the inferior articular process of L4, and so this was already kind of annotated to be an osteophyte that was probably most likely the main culprit of the patient's radiculopathy. So I'm just trying to move it around here and get an idea of the anatomy of the osteophyte. Again, trying to remove some of the lamina, the L5 portion. And so again, I'm trying to remove the bone around it as much so I can kind of remove the osteophyte en bloc. And you can see that the ligamentum is starting to thin out here, so this is probably as much of the decompression I want to extend caudally. And so you want to annotate these areas when the ligamentum thins out, because that's again kind of a marker to give yourself on the location of where you're at within the spinal canal. The curette is a great tool to use during endoscopic spine surgery. So here I use the curette to remove some of the ligamentous attachments to the osteophyte. Again, the dura is right there on the side, so I want to make sure I remove any adhesions from the dura to the osteophyte. This can be a little bit dangerous, as you want to make sure that you don't obviously get a dural tear when you're doing this. That's why I kind of come in from the side here, and I try not to essentially pull it too much, but use more of obviously the sharp edge of the curette to remove the osteophyte. So you can see here this portion is moving relatively easy. And again, I'm going to start using a pituitary to try to remove it en bloc rather than just chomp at it. The more you chomp at it, obviously the higher risk of dural tear. And so it's easier sometimes to free it up with the curette first before you go in and use the pituitary. Essentially, if you use the pituitary, you can also pull a big piece of the dura off, and that's obviously not favorable. So again, this is really not going to fit through the working tube, and so I do have to kind of remove it piecemeal through the working tube, and so that's what we do here. So now you can see that the osteophyte is gone. There's remnants of the cysts down below. And the reason I call this a cyst is because I believe that it was a little bit of a combination of a hypertrophic facet as well as a facet cyst. And so here I can start using the keratins to remove some of this softer kind of cartilaginous osteophyte. Some of it may be kind of cartilaginous facet capsule, and so I also am kind of using the keratin to free up some of the adhesions from the dura at this area too. So I always make sure that I come in with the kind of shoe of the keratin back to the dura. I never want to use a sharp end towards the dura, and so I always take 90-degree bites, just obviously like you would during an open procedure. So again, these keratins are well made, but again, since they're endoscopic, they're not very strong. And so you can see that superior lateral aspect of the lamina is a little bit thick still. And so I really try not to waste too much time using the keratins to get this bone, because it's not going to be fruitful. And so I'll get the small shell, but then I'll use either a Sidecutting burr or a diamond burr to really thin out the bone before I start using the keratin. So in my mind, the keratin is usually used for kind of small bony work or any tedious work that I want to decompress, rather than doing it or using it for the bulk of my decompression. Here we'll start using a side cutting burr. This burr is very aggressive, so you really have to be careful with holding on to it because it'll stray forward when you start it. And so I use this to extend my decompression laterally. You'll notice that I don't take any cortical bone up high with it. This is really just to save time on decompressing the lateral recess. And I only do it a few seconds at a time to make sure that I'm obviously not straining into the dura and removing any soft tissue that may be in my way. So I switch between this and the diamond burr as well as the Kerrisons. I'll use the side cutting burr for really big pieces of bone in the lateral recess. As you can see here, I'm getting a nice decompression with it. Again, I don't want to use this solely for my entire decompression, just due to the risk of dural tear. A lot of times I'm also pausing between using the burr to allow the bone dust to leave the tube. Again, I don't want to use the burr when my view is obscured, and because again, that's really where you can get into a lot of trouble. I really take my time with the side cutting burr to decompress the lateral recess. I'm using the Kerrison here to retract the dura a little bit, as well as take some bites so I can continue the decompression laterally. And so as you can see, the traversing nerve root is coming into view. I'm trying to assess exactly where the anatomy is, where the traversing nerve root is, what course it's taking. Remember that we have a spondylolisthesis at L5S1, so the L5 vertebral body is sliding forward, and that's going to put the traversing nerve root in a different anatomical position than the traversing nerve root would normally take. So here it almost looks like an exiting nerve, but we know that we're at the foramen, so we know that's not really possible. So the reason it looks like it's coursing a little bit laterally there, like an exiting nerve root, is due to the fact that the L5 vertebral body is listhesing forward. So again, I use the Kerrison to remove some of the soft tissue here. I want to take a view of the traversing nerve root more caudally. And so this is really what you have to think about when you're doing this is, where exactly the traversing nerve root is, what course it's taking, and that ultimately will help you decide where to decompress. And so here I'm moving the joint, making sure that one, I'm not destabilizing it. I'm just getting a feel for the anatomy of the joint. And so I want to make sure that I'm really checking all the anatomical kind of considerations of this decompression. Again, we're really only working within kind of a 8 to 9, maybe 10 millimeter area here. And so a lot is going on in this area. You want to make sure, like I said, that you're not decompressing somewhere where you shouldn't, or obviously decompressing too much. And so that's why I really am not extending my bony decompression up dorsally, and kind of really kind of extending it eventually, but more laterally. And so this will help stabilize that segment and obviously not take too much joint. And so you can see here this capsule is a little bit redundant, and so I'm trying to remove a little bit of that as well. Again, I don't want to destabilize that capsule too much, but I do want to try to remove any soft tissue that I think is potentially impinging that nerve root. So another great tool to use is the ball probe, and so I actually want to feel the pedicles, make sure that, again, I'm really in the right area. I know that I've stressed this a lot, but this is really a very important point of endoscopic spine surgery. It's very easy to get lost, even when you have a view such as this and you think you know where everything is at. And so I'm trying to remove any adhesions here, get a feel for the anatomic variation of the traversing nerve root, and sometimes you can see it come off a little bit lower, sometimes you can see it come off a little bit higher. And so that's really what I'm trying to do here is what is the anatomical course of this traversing nerve root. Here I'm trying to feel the pedicle, check the anatomy, because this is a very complicated anatomical spot to work in, especially when you have pars defects, the low below, spondylolisthesis. If you remember the MRI, the spondylolisthesis was greater than 4 or 5 millimeters, so we know that traversing nerve roots can be in a different anatomic position than it normally would be. And so, again, you want to control this bleeding fairly quickly, and I'll use the RF probe here in a minute to do that. So we'll continue with the decompression. You can see that I've already removed some of the bone previously, and that traversing nerve root is coming in a little bit more in view. So even though I can see the traversing nerve root somewhat, I do want to continue the decompression out laterally until I can really know that that traversing nerve root is decompressed. When this patient stands, that foraminal area is going to get smaller. You can see here where the RF probe was, that nerve is a little bit erythematous, and so you'll see here once I open up the lateral recess in a little bit that this really was the culprit of the patient's radiculopathy due to the irritation of the nerve root. So we've gone through and increased the expansion of our lateral recess with Kerrison's, and so as you can see here, the cortical area up above is still maintained. Again, I know I keep stressing that that I'm only decompressing kind of inside out, right above the traversing nerve root. Again, I'm going to keep stressing that this is important for stabilization of that segment. So you can see here that nerve is very erythematous, and so I believe that, again, this was mostly the culprit for that. You can see that I kind of toggled the superior articular process there, and so I want to do this just to make sure that, again, there's no unstable segments, there's not a big piece of bone that I need to further evaluate, and so I'm really removing some of this bone that's right over the nerve, and that's going to be the lateral edge of my decompression. So I'll remove these small fragments here with the Kerrison. Again, the L5 nerve root is very tenuous, just like the C5 nerve root and the cervical spine, so you have to really be careful to not ding this nerve up too much. So I'm really cautious of the Kerrison when I'm taking these bites. So you can see that nerve is just irritated kind of circumferentially, and so I believe the stretch of the spondylolisthesis does cause some of this irritation, but I think it's really the compression against the bone and that osteophyte that causes it. So we can see here that the nerve is probably adequately decompressed at this time. I'll remove that kind of caudal lip there that it's still traversing under, but you can see there that that's a good view of really the impingement of that bone onto that nerve root. And so this is a really great example of kind of ultra minimally invasive decompression of this. Could I have done a fusion and a 360 at the L5S1? Potentially, but I was worried about that hypertrophic facet and the impingement on the traversing L5 nerve root. So my fear was that if we went with the 360 first, that we would potentially still have radiculopathy due to the hypertrophic facet cyst. And I didn't want to entertain a 2-level surgery when I could potentially just attack the traversing nerve root. And I had counseled the patient that if he didn't get good relief with the endoscopic decompression of the traversing nerve root, then we could move forward with that 360. But at least I would be able to provide the decompression of a 2-level surgery endoscopically first, allow him to heal from that, see what his symptoms are, and then potentially go back and do a 360 later, do a large cage with indirect decompression and correct a spondylolisthesis at L5S1. And so some people could advocate, well, you could do a 360 and then do this endoscopically at the same time. This took me roughly about an hour. It's not something that I like to entertain doing at the same time as a fusion, mostly for logistical reasons of my access surgeon being in a different hospital than my tower. But again, if I can do this endoscopic decompression first and get the patient a few years or whatever length of time that he's pain free, the spondylolisthesis at L5S1 looked pretty stable. on flexion extension radiographs. And so again, if the patient's not having any left leg symptoms and bilateral L5 radiculopathies, it's hard for me to indicate a 360 for just a single dermatomal radiculopathy. And so this is why I like to do the endoscopic decompression for kind of single level or single dermatome radiculopathy. So you can see here, this is important as I remove these last pieces of bone here along the lateral recess. I know that the traversing nerve root is starting to take its exiting course at the L5 pedicle down below, and so I'm not going to want to take too much more bone during my decompression in order to prevent destabilization of that segment. So you can see here that traversing nerve root is entirely decompressed. It's going to take a little bit for the irritation to subside, so I counsel the patients that you may experience some numbness following the surgery, and they may have some ridiculous symptoms that kind of come and go over the next couple of weeks. I find that this happens sometimes with endoscopic decompressions, and a lot of times I tell patients I equate it to, like, sitting on your foot and then falling asleep and then you're waking up. And so once patients know this, they're typically reassured. Before I started to counsel patients on this, I'd always get phone calls about patients stating that they had numbness or still had some particular radicular pains that happened on and off, and they were somewhat worried about that. And so, but they all typically subside after a couple of weeks. So that's a good thing to tell your patients. And so again, roughly, about a 10 millimeter area of decompression here. Again, you have to take into account that endoscopically, this looks like it's a very large area that's decompressed, but you obviously have to realize you're working through the tube and through the camera, and so everything's magnified. And so this is what I really love about endoscopic spine surgery, is that this decompression, albeit somewhat large here through the camera, is very small. And I've had a couple of patients I've had to take back and do open decompressions for separate reasons. And when you go in and see that laminotomy, it's very tiny when you're extending it during an open procedure. And so that's the nice thing about endoscopic spine surgery. So again, I think we're done here with the decompression. I continue to get some of this ligamentum flavum here, but again, I don't spend much time doing that because this is typically where I end up getting myself into trouble when I don't know when to stop. And so I didn't spend too much more time doing this. And so that's another good aspect of surgery to really learn and remember as you get into practice, is knowing when to stop. And so typically if I go into these corners, that's when dural tears happen. So I'm kind of joking my scrub tech right now that this is when I need to stop the decompression. So thank you for watching this video. I hope you learned a little bit about diagnosis of these kind of more complex radiculopathies and kind of the treatment options, especially using endoscopic spine surgery.